Okay, thank you for the invitation. So this is my outline for this talk. First of all, I would start with updating the clinical context in kidney transplantation. So most of clinical trials in transplantation had been done relating to new immunosuppression in order to prevent acute rejection. But in the last 15 years, there are very few drugs that have been approved, only belatacept. So this is probably the cause because investment, the pharma investment in this topic has been decreased. There are many also, there were many drugs that failed in the field. This is the classical picture that has been shown in the last 10 years. So we found that there is a significant increase in graft survival during the first year, and then the curves run in parallel. So this has been said that graft survival beyond this first year has not improved in parallel. So because the causes of graft loss are chronic graft failure and also patient death. But the question is this: if this is still true now. This is a review from our transplant activity in our center in last year, 10 years ago, and 20 years ago. You can see that the number of transplants are increasing, and also there are several types now of transplantation. We have living donors, DCDs, ECDs, etc. So the situation is quite complex. Also, donor age is increasing. That is probably the same in most transplant units, more than 20 years in donor age. And also the recipient age is also increasing, and diabetes is also present in many patients before transplantation. So the figures regarding the outcomes, the early outcomes after transplantation, are also different. You can see that DGF is now very frequent because of the type of donors we are using, and also rejection is very low, and this is probably the same in most transplant units last year. Around 3% of our patients experience acute rejection during the first year, and this is graft survival. So in the last 20 years, at least in our center, there is not much significant improvement in 1 year graft survival, although the causes of graft loss are different. In the 19s, acute rejection, and now death with a functioning graft, and also never functioning kidney. So probably the figure that I have shown you at the beginning of my talk should be updated. And this is because we already apply the precision medicine in order to stratify at least the risk of rejection. So we use donor-specific memory assessment. Mostly is B cell, but also in some cases T cell. And by this stratification, we can use several types and several intensity of immunosuppression, and this is the reason why we have now these good results, at least in terms of acute rejection. So the answer to my first question is that probably the situation is not that shown in the picture, but because the graft survival is quite similar during the last 20 years. However, donor and recipient characteristics are completely different. Acute rejection is not a major issue now, and DGF is very common. And death with a functioning graft is the first cause of graft loss. And this is, at least in my opinion, the current scenario. But despite this view, so clinical trials are still focusing on acute rejection. And just an example, this paper is the Transform study that has been published this month, and you can see the composite endpoint that is GFR, but also treated biopsy-proven acute rejection. So again, there is acute rejection in the primary outcome. And you can see that this outcome is around 10%. So in my view, over the past 15 years, all interventions and developments to reduce acute rejection fail, so we need to move on and to look for new endpoints in clinical trials. So the next part of my talk is the lack of surrogate endpoints of graft failure. And this is a big problem for us because there is no one accepted surrogate endpoint for all-cause graft failure. We are talking about the de novo DSA, subclinical rejection, or GFR, etc. But at the end, there is no one accepted. And this approach is based in oncology experience, because you know that the oncologists succeed to find new drugs to treat patients with cancer. But and because these surrogate endpoints are accepted to shorten the trial duration and the decrease in the enrollment numbers. And this is that we need to perform our clinical trials in transplantation. But in my view, there are some differences between oncology and transplantation, mostly regarding the objective of the treatment, but also the duration of the predictive interval, and also the time for the biomarker assessment that is quite different between both situations. Just one of these surrogate endpoints would be the protocol biopsies. And you know that protocol biopsies have some problems regarding the predictive value, but it is quite accepted that inflammation, even the BAM classification, is related to the outcome. But sometimes inflammation could be protective, and we have shown this in a paper published several years ago, showing that if the infiltrate have these regulatory T cells, the outcome is good. And also, in my opinion, the use of protocol biopsies in clinical trials may introduce some confusion regarding the diagnosis of biopsy-proven acute rejection, because sometimes this rejection is diagnosed in clinical or subclinical situation, and you know that the prognostic value is completely different. A few words about the GFR. This is an example of clinical trial, and we participated in this trial several years ago. And this trial consisted on cyclosporine withdrawal in patients treated with steroids and MMF. And there is significant, very early improvement in GFR. And that seems good. But if we follow the patients for years, that we found is that those patients without cyclosporine experience a progressive increasing number of graft loss because of probably under immunosuppression. So this is an example of the limitation of GFR when we are talking about surrogate endpoints in clinical trials transplantation. And finally, there are other surrogate endpoints in clinical trials, and just as an example that by using biomarkers like ELISpot or some urinary cytokines. This is a study that looked for these biomarkers during the first 2 years after transplantation and trying to identify or to the prognostic value regarding 5-year graft survival, and they found that these biomarkers during the first years are not related to 5-year graft survival. So there's also a limitation by using this kind of biomarkers. And this is because when we are using biomarkers as a surrogate endpoints in clinical trials, sometimes the predictive value of these biomarkers is decreasing over time. So as an example, so it's very easy to if the hand become wet, it's clear that it's raining, and probably I will need an umbrella to prevent to be soaked. That's very easy to diagnose and to prevent. So the problem is when it is cloudy, so it's very difficult. So this is a clear example of what we are happening now by using this kind of biomarkers. So, but we have now some opportunities, I think. Perhaps the use of precision transplant medicine will help. And also we have opportunities to look for some comorbidities which have an impact in graft survival. I recommend you this very nice review published this year in the Journal American Society of Nephrology by Martin Neissens and Grishaw. And they describe very well the different types of biomarkers that can be used in clinical trials and put these biomarkers in the clinical context. So this is an example of a cartoon published in this paper. So you have here all the transplant population. So you can use a risk susceptibility biomarker to identify patients with at risk of rejection, for instance, interferon gamma ELISpot. So then you can monitor these patients by using also non-invasive diagnostic biomarker, urinary cytokines, for instance. And then you have the suspicion of acute rejection, so you can perform an invasive diagnostic biomarker, a biopsy, and to confirm the acute rejection then, you have these patients with the confirmed acute rejection, and then you can use the prognostic biomarker, for instance, the molecular microscope, to define the prognosis. And then also, and here we have no predictive biomarkers, but we are probably in the future we will have some of them. We will have these predictive biomarkers in order to choose the correct treatment, and then we can monitor the effect with some monitoring biomarkers. This is the scenario, several different types of biomarkers that can be used to design clinical trials. Not only one, so several types. And this is scaled. Clinical trials probably will be the future. But in the meantime, I think we have a lot of opportunities, a lot of topics to be investigated, and there are very few clinical trials on this. Organ availability and quality, DGF, we haven't any drug to treat this, to reduce DGF, very important, you know, more than 1/3 of our patients experience DGF. Renal protection, cardiovascular mortality. Post-transplant diabetes is a clear example of this kind of trials that we need. We need these trials investigated to prevent and to treat this post-transplant diabetes, malignancies, infection, and so on. And this is we have done in the last years in our unit, trying to identify some markers to guide immunosuppression or to optimize cardiovascular profile, or to investigate the treatment of secondary hyperparathyroidism. So this is my final slide of this short talk about conclusions. So the first one is the overall kidney transplant outcomes remain unchanged over the last 20 years. and this is at least that we happen in our center. However, these results have been achieved in a completely different and unfavorable donor and recipient profiles. And this is good because we have the same results with bad combinations. Susceptibility biomarkers have improved the immunological risk stratification before transplantation, and this is the cause why now there is a very low incidence of acute rejection. Non-invasive, predictive, and monitoring biomarkers are still on debate in transplantation, and we need to move on and to progress in this trying to define the best. The granular phenotyping to identify patients at risk for the event that we want to investigate is critical to define the study population. So we need to concentrate efforts in small and well-characterized populations in transplant with the risk of the event in transplantation. Also, new clinical trials should also focus on current long-term causes of kidney allograft loss, and this is very important because we have very small number of clinical trials in most of the major complications that we observe in our transplant population. And finally, governments, scientific societies, investigators, and also the pharma should create alliances and platforms to promote these new clinical trials in kidney transplantation. So thank you for your attention.
Thank you. This presentation is open for questioning from everybody. Anybody? No questions, but so it's a little depressing then, is it? There's no new trials. There's nothing coming. Can we do something with what we have? I mean, you show us the biomarkers. We could start using them. But you think, for instance, that we're dosing tacrolimus correctly? We've been using it for 25 years. I'm not sure we're individualizing the dose enough. You have any thoughts on that?
So it's very difficult to answer this question. This is the current scenario is this. We have less pharma investment in clinical trials in transplantation because the outcome is acute rejection now is very difficult to overcome, at least to reduce or even to have non-inferiority results. But I think that there are many topics that need to be investigated in regular clinical trials. So a clear example is the lack of evidence of treatment or even prevention of post-transplant diabetes, that this is a major complication after transplantation and that have an important impact in terms of patient and graft survival. So the guidance of immunosuppression, I think, is quite complex because depends of several issues. But I think probably the new biomarkers, the combination of several types of biomarkers, and put these biomarkers in a real clinical context may help. But I think we need to move on and to have finding to invest in this, to investigate in this area.
Do that. We need some money. And Clemens, you need money to do your research.
Of course, money is a problem, but another problem, maybe we focus too much on acute rejection, and acute rejection is a surrogate marker, and as you point out, acute rejection is gone, but outcomes are not getting better, so it's a perfect example that acute rejection was a wrong surrogate marker, and we focused on this, and maybe we should have focused on diabetes much more. And maybe I don't know, maybe we still should use cyclosporin because in order to prevent diabetes and have maybe a little bit more rejections as shown in the direct trial or so. So I think this is also questioning our wrong decisions to focus on acute rejection, and we have to focus on real important outcomes maybe, or much more important outcomes.
I completely agree.
Thank you. And we have to move on due to time. Thank you very much.
Next speaker will be Christian Morat from the Heidelberg